All right, good afternoon. This is room 4. This session will be intimate partner violence screening with homeless veterans, technology, policy, and practice considerations for healthcare professionals. Our speakers today are Dr. Sean Liu, Director of Communications from the Homeless Programs Office of the Veterans Health Administration, the United States Department of Veteran Affairs. Aaron Solanskis from VA Mid-South Healthcare Network Homeless Coordinator at the United States Department of Veteran Affairs. And our last speaker will be Leanne Bruce. She is the National Program Manager for the Department of Veteran Affairs. Okay, take it away.
Great. Thanks so much. Hello, everybody. Thanks so much for joining us today on this presentation where we're going to talk about intimate partner violence screening with homeless veterans. As per the introduction, I'm Sean Liu, really excited to be here with you today. We've got a set of slides, but we really want today's presentation to be more of a discussion and a conversation. So we're going to toggle the slides off and on throughout. But before we dive on in, I just want to quickly go over the learning objectives for this session. So here are objectives. First and foremost, we hope that at the end of about the hour and 10 minutes that you're here with us, that you'll gain an improved understanding of the state of the research on the intersectionality between intimate partner violence and homelessness among veterans, that you also hope to gain an improved understanding about how IPV screening and follow-up care is delivered in our VA healthcare settings, and hopefully that you'll gain an understanding on how to implement these type of screenings in your own healthcare settings as well. I want to acknowledge today that we have kind of an interesting presentation problem that we're going to try to solve, that when we think about intimate partner violence, right? It's a very, very broad topic. When you think about homelessness, especially homelessness among veterans, it's another broad topic. And when you put that under the banner of VA, one of the largest agencies in the federal government, and then try to scaffold up into what is the topic for today, which is the intersectionality of the two, right? Intersectionality of intimate partner violence and homelessness. That's a lot of background information to try to give you enough foundation so that we can have a meaningful discussion about how these two important topics interact. But challenge accepted. We're going to do our best. So with that in mind, I'm actually going to drop down the slides now and kind of get to know our subject matter experts really quickly. So joining us today is Dr. Leanne Bruce and Miss Aaron Solanskis, both from VA. Aaron, Leanne, really appreciate the opportunity to moderate this panel discussion with you both.
Thanks, Sean. It's great to be here.
Great to be here. Thank you, Sean, for doing this and putting it all together for us.
Yeah, really, really excited about it. Okay, let's get to know you a little bit more. And in the process, I think understanding your two different worlds. And Leanne, I want to start with you first. You are one of our national leads for intimate partner violence and the services and programs that VA provides to veterans who may be impacted by intimate partner violence. So can you both tell us a little bit about yourself and what VA does for veterans who might be impacted by intimate partner violence?
Absolutely. Thanks for this opportunity. I have been a part of this program, since its inception in one way or another, trying to support it. The Intimate Partner Violence Assistance Program was implemented in 2014 officially. So we've been around for a little while, and we are the result of a task force of subject matter experts that came about through the Secretary of the VA. Knowing that this was a problem brought a lot of brains together to say, what do we need to be doing about this problem for our veterans and their families? That resulted in a guide for implementation that started in 2014. I came along in about 2016, 2017. I am a clinical social worker by training. So my entire almost spanning 3 decades career has been sprinkled with working with individuals and families who have been impacted by intimate partner violence, domestic violence, trauma, and so forth. So it was, really a amazing honor for me to be selected as the National Program Manager for the VA's Intimate Partner Violence Assistance Program. And we try to run the gamut of helping veterans, their their significant others and VA staff as well who are impacted by this national epidemic of intimate partner violence. And we do that by being very comprehensive. We serve those who experience intimate partner violence in different forms, all the different forms, those who use intimate partner violence or are at risk of doing so. And we really have delved into the realm of wanting to prevent intimate partner violence by helping to support healthy relationships. So you'll hear us talk a lot about promoting healthy and safe relationships because we're across the board trying to help our veterans, really establish safe, healthy relationships, that being one thing that is a huge protective factor against things like homelessness, poverty, suicide, homicide, and all those all those other things that we hear about with veterans. So I'm at the VA Central Office, which is the national office to oversee some of these programs working within the realm of social work and care management and social work programs. So we do delve into the policy and procedure end of supporting this work.
Right.
Thank
Great.
you.
Thanks so much. Yeah. Thank you so much. I know that the idea of healthy relationships is probably going to come up quite a bit, especially when we talk about like some of the screening tools that we use, the services we provide. It probably goes to no surprise that healthy relationships, or maybe the lack of healthy relationships or estrangement of relationships, is also a big issue for veteran homelessness, which is a great opportunity, Erin, to pivot over to you now. As one of our regional leads for veteran homelessness, tell us a little bit about your role and what types of programs and services does VA have to help veterans who are experiencing homelessness or housing instability?
Sure. So I serve as the Network Homeless Coordinator for the VA Mid-South Healthcare Network. The Veterans Health Administration is divided up into 18 different regions. And within VA, we call those Veteran Service Organizations, or VISNs. And so I'm in the region that is known as VISN 9. So that may be a term I use for that. It spreads across 238 counties in 7 states. Most of our region is encompassing Kentucky and Tennessee, but we also have portions of Arkansas, Mississippi, Georgia, Virginia, and Indiana. So essentially what it means is that I'm responsible for the oversight of all of the homeless programs at VA healthcare centers across our network. And in addition to my primary role as the Network Homeless Coordinator, I also serve as our network's Intimate Partner Violence Assistance Program champion. Did you want me to describe the homeless services that VA provides?
Yeah, that would be really helpful. And, Erin, I want to kind of acknowledge a couple of things that you mentioned, because folks may not realize just how massive VA is, right? Like, and a lot of times when folks hear VA, they either hear about like the hospital system or maybe like the benefits administration, things like disability compensation or 9/11 GI Bill sort of stuff. And just kind of acknowledge that we largely sit in the healthcare administration side of VA. So all the hospitals, all the doctors, primary care, specialty care, that's all of us. But Erin, one of the things that I heard from you just now, which was really interesting, that sounds like puts you nicely to be essentially a national leader on this particular topic, is that you actually inhabit the intersections as a regional homeless lead, but also an intimate partner violence champion at your region. Your role is basically in the intersection. So before we get into the intersection side, can you share a little bit more about like what type of services, as you were sound like you were about to do, what type of homeless programs and services does VA have to help veterans?
Sure. So the VA offers a wide range of programs and services that cover a full spectrum of housing instability and homeless experience, all of which are built around the concept of housing first. And Housing First is an evidence-based model that prioritizes housing and then assisting veterans to access healthcare and other supports that promote stable housing and improved quality of life. So the VA homeless programs start with outreach, engagement, assessment, and referral to services that serve as a front door for homeless veterans to access the VA. It includes street outreach to unsheltered individuals and operation of things like a national call center for homeless veterans, which is a 24/7 hotline that veterans who are homeless or at risk can get connected immediately with care within their own community. We also offer residential services, such as the Healthcare for Homeless Veterans Contract Residential Services and the Grant and Per Diem program, both of which provide temporary placements in the form of emergency and transitional housing. There are also permanent housing programs within VA. Those include the Supportive Services for Veteran Families, or SSVF, as well as our HUD-VASH program, which is HUD and VA supported housing. Both of those programs connect veterans to affordable housing within their communities. And these services also come with either short-term or long-term rental subsidies, case management, and varying levels of wraparound supportive services to ensure that the veterans have all the necessary resources to stay housed. And finally, VA also has programs that assist veterans in the criminal justice system access VA care. We help veterans gain meaningful employment, and we take care of their health needs through primary care that is tailored to unique access barriers that veterans experiencing homelessness face. So it's a large menu of services.
It's a lot. Yeah, no, that's a big range. And yeah, and I heard, and you mentioned it, like that's a wide spectrum from like front door. I think we also do some prevention, got some temporary shelter, as you mentioned, permanent housing. You also mentioned, I heard, employment, some criminal justice work. I know we could spend an entire session on each of those different topics as well. And for those who are listening in and watching, even if you're not working with people experiencing homelessness or veterans, a big part of what we hope today is to give you some, maybe some tips and tricks, some lessons learned, especially if you work in community-based settings, right? So, when you think about traditional healthcare services, you have your inpatient and your outpatient. But Aaron, correct me if I'm wrong, a lot of the work that the staff in your region, in your VISN, that they do is kind of what we consider community-based. They're actually going out into shelters, the woods, people's homes, seldom doing the work inside an outpatient or inpatient setting. Do I understand that correctly?
You sure do. That's absolutely right.
All right. All right. Excellent. Aaron, I want to stay with you for a little bit, especially from your vantage point as the regional lead for homelessness and the champion for intimate partner violence. Can you tell us what we know about the intersections? Like, why is this topic so important? More for, not just for you, because I know this is something you're passionate about, but why is this a topic important for the veterans that we serve?
Yeah, glad to. So we know that research has shown that those who experience intimate partner violence have an increased vulnerability to financial difficulties, suicide risk, and homelessness. IPV, or intimate partner violence, has also been identified as a risk factor for homelessness. The concept of our pilot was to identify and treat all factors contributing to veterans' homelessness or housing instability. But first, we know we need to identify what those factors are. And so that's really why we did the pilot that I think we're going to talk a little bit about.
Yeah, some really practical stuff as well. Leanne, I want to get your take as well on this particular topic. What else do we know about the connections between intimate partner violence and homelessness or housing instability or housing insecurity, especially from your perspective on the other side of this topic, squarely in traditional kind of like intimate partner violence services?
Sure. And if you want to switch to slide 4, gives us a little bit something else to look at, but gives us a little bit of how this all started. This conversation really started much like what we're doing right here at a meeting in Aaron's region where we were talking about this very thing. So the coordinators, every VA medical center or facility basically is covered by an intimate partner violence assistance program coordinator. And a couple of years ago, we were having a meeting talking about this very issue. We know that homelessness is a prevalent issue and connected heavily to these other issues like homelessness, joblessness, poverty, healthcare issues, all of those kind of things. It doesn't occur in a vacuum like this one thing. It's connected to all these other things. And we were actually just talking about how we know a lot about, there's been a ton of research out there about women veterans and their homelessness and some of the reasons they might be homeless. And intimate partner violence is pretty well researched with regard to female veterans experiencing intimate partner violence. So as it's, we were like scratching our heads saying, okay, we understand that women oftentimes are homeless. In fact, 3 times more likely to be homeless if they also have experienced intimate partner violence. So we know that that's very prevalent. And we know that that's related to a lot of times fleeing a domestic violence situation where they're leaving a partner or leaving a situation due to intimate partner violence. We were sitting there realizing, talking about what we don't know. And I was saying, I happened to be in their vicinity and was attending their regional annual conference. And Erin, as the regional representative for intimate partner violence, we were all sitting around the table, and I said, I really wish we knew more about the things that we know in our gut. We know intuitively that it's not just women. Men experience intimate partner violence as well, and they they might be fleeing a situation. They might be homeless as a result of experiencing intimate partner violence. But on the other flip side, both men and women could also be homeless having used intimate partner violence. And in our terminology of intimate partner violence is very broad. We use the hurt, insult, threaten, scream screening that you'll see later. It's pretty extensive, but we really drill down into the types of intimate partner violence that might be happening, which may be just the warning signs of relationship stress, where that people are yelling at each other and calling each other names, and things like that. So that's all within the realm of what we call intimate partner violence. And sometimes people leave a relationship. Sometimes people are using those behaviors and are asked to leave the relationship and then therefore leave the home. So they could be homeless or having housing insecurity, whether they're experiencing or using intimate partner violence. But to be honest, there wasn't a lot of research out there published that was able to tell us and inform us what kinds of dynamics are going on with regard to our veterans, irregardless of gender, that might be contributing to their homelessness and housing insecurity. So really, this project was born of people sitting around a table saying, hey, we don't know a lot about this. How can we find out more?
Yeah. And Leanne, I know we didn't go over this with the prep, but you mentioned kind of the idea of not total lack of research, but the under research of the experience of intimate partner violence among men. And I kind of would assume, and maybe correct me if I'm wrong, that this is, although we talk about intimate partner violence in traditionally heteronormative kind of ways, right? Men as the perpetrators or users of intimate partner violence, women as the victims, survivors, or experiencers of intimate partner violence, that in many instances, like, it doesn't, acknowledge gender or relationships, that men, heterosexual men, LGBTQ men, trans women, the full range of experience, people can experience intimate partner violence. And that in many ways actually has, I would assume, some implications on how we think about who is the ideal candidate to be screened. Like, what are the indications for screening? Am I understanding this correctly?
Yes, absolutely. And thank you for, talking about that. We really are trying very much in our program to be careful about our language, be very inclusive in our language, break down those stereotypes and those myths, basically. And we use trauma-informed language, person-centered language. We try not to label the individual. We talk about those who experience intimate partner violence, those who use intimate partner violence. We try to take the gender factor out of it because of those stereotypes. It kind of leads us down the wrong road, to be honest. And when we're trying to be very inclusive, we want everyone to be welcome and feel that we're embracing them coming and telling our story, regardless of of the gender of the situation, whether they're experiencing using or they're in a bi-directional IPV relationship where both parties are using and experiencing. We want to get involved early. We want to mitigate the risk and so forth. So those are all the things that are very prevalent in how we operate the Intimate Partner Violence Assistance Program, and what we've been able to see, in studies and projects such as this. It's really opening our eyes.
Yeah, really great stuff. Leanne, I want to stay with you a little bit. You mentioned kind of a screening tool, and now might be an interesting opportunity to just talk about how does VA like screen veterans. And I want to kind of frame this up in the idea of like safety and stigma. I know that stigma, and you just kind of touched on this a little bit, that stigma can be such a big factor in whether or not somebody can access services, right? Does the shame, and however that shame is manifesting, prevent them from seeking care? And in many instances, because of things such as shame, stigma, lack of safety, it's really incumbent upon us at VA to be proactive in identifying veterans whenever possible, not just waiting for them to say, oh, well, I'm a victim or a survivor of, will you give me help? Like, no, we actually have to go find out. But I think it probably would be good to elucidate precisely how we do that. So can you share a little bit about like, how does VA go about screening veterans for intimate partner violence?
Absolutely. And if you want to pop down to slide 10, it gives us a little bit of an overview, and we can look at the others. But we actually have a 3-level screening process. Our very first screening process, and everything that we do, what you have on the screen, is talks about our trauma-informed care approach. So trauma-informed care is all about it. And this really gets into, this isn't just clinical. This is policy. This is procedure. This is environmental. This is theory-based, conceptually based. We had to take all of these things into consideration in developing this very involved screening protocol. So when we come over to talk about the project and the pilot, it's good to know how involved this really is, because when Erin and her team in that region, in Des region, decided to take this on, it's a big deal. And they didn't have to. So I want to say there's a lot to that. But when we look at our screening protocol, every step of the way is based on trauma-informed approaches. So we look at the environment. Is it safe? Is it inviting? Do people feel welcome? Which, really encompasses our language that we're using, and, all of those kind of things that break down those barriers. We have to look at policy. And make sure that, that our policies are not re-traumatizing someone, or the procedures that we're using, the tools that we're using, all those different things had to be examined in implementing our screening. And then, does it empower? Does the intervention or what we're doing empower the person? Do they have choices? So there's actually 6 steps in a regular screening. And then our screening involves, if you go to the next slide, a primary screen, which, as I mentioned, uses Dr. Sharon's hurt, insult, threaten, scream. That's really supposed to be SCREAM screening. Sorry about that. And so it's really nice, because we do not like, I will just put it out there, we do not like the "do you feel safe at home" screening question. That could mean anything under the sun. We want to really drill down and ask someone, what's going on in your relationship? Is it safe? Is it healthy? And we educate by using this screen. So we're able to identify the type of behaviors that are going on. So is it verbal? Is it emotional? Is it threats? Is it physical? Is it sexual? And to what extent? Is it never happening? Great. Is it happening once in a while? There's screaming going on. We have so many interventions available within the VA and with our community partners to get involved with couples early when stress is overcoming, their coping skills. So we want to know early. We have a very low threshold because of that, because we want to get them into services and offer them things early. And we also want to mitigate the risk where people are saying, yeah, this is happening often or frequently, or it's, it's physical. If any of these are positive, if we go to the next screen, automatically in that same session, and anyone who's been trained to do this can do this screening. We want a no wrong door approach, that anyone coming in is able to obtain this screening with someone that they trust. But immediately, if there's any yeses to the first screen, this second one pops up. And we ask if the intensity is increasing, frequency or severity, or if the person has ever been choked or strangled, strangled being the medical term, choked being the one people mostly relate to. We know that if a partner has ever used strangulation or choking in an incident with a partner, it raises their risk of lethality by 750%. It is one of the most crucial indicators of identifying danger and risk in a relationship if that has ever happened. And of course, if they feel like they're fearful that their partner may kill them, those will tell us if this is something that we can just do bring them back in later to do a safety plan and work on relationship issues versus we need to act quickly and offer that person some assistance. And what happens next is we have trained providers all through the system who that person can see that very day to do a more thorough assessment of their situation and do safety planning and get them into intervention, or in some cases, potentially be helping them create a plan to flee. And that plan may actually involve reaching out to the homeless veteran programs to see what's available for them. And sorry, that was a little bit long, but that is our screening in a nutshell.
Yeah, Leanne, I'm noticing the questions are pretty raw and candid, and I imagine that there's a lot of maybe training that has to go into the providers who would be asking these questions, both to maybe regulate their own discomfort with asking such very frank and to the point questions, but also making sure that they're putting the veteran or the patient first in the interactions. Like, well, we may be uncomfortable asking this, but imagine them experiencing this and having to say yes. So I imagine there's a lot of training that would go into making sure that this is done. You said the word trauma-informed, non-stigmatizing, non-further traumatizing way.
And technically, I wouldn't say a lot, but there is training, and then there's ongoing support and consultation. So our Intimate Partner Violence Assistance Program, and you might hear me say IPVAP. That's what I mean. That's a mouthful. IPVAP. Our IPVAP coordinators are there, boots on ground, to help with consultation. They go do the training. The training is really minor. Like we say all the time, this isn't rocket science. You can do the training, but it is that trauma-informed comfort level. We want to make sure people are comfortable, and we want to make sure that we've built the screening in a particular clinic around the worst case scenario. Vastly, the people say, no, it's not happening, or no, we're just arguing a little bit. And we also promote universal education. Even if they say, I don't want to be screened, we offer them, local information. We talk to them about it. We give them resources, National Domestic Violence Hotline number. If they are screened and they say no to everything, we still offer that, so we want to make sure we know how underreported it is. We know that we could ask people 15 times and they're never going to say yes, but they'll take that information and they'll call the hotline. So we're trying to cover every base. Yeah. But with regard to the staff, the screening itself doesn't take a lot of training, but a lot of times it does take that ongoing consultation and support with staff if they run into something like this and they need that. Yeah. And that's what the coordinators are there for.
So in my understanding as well is that this is meant to be like a universal screening. So our goal at VA is really to screen everybody, not just wait for indications, because sometimes there may not be indications. People might intentionally, be able to present as if everything is fine when things might not be. But I think if I remember correctly, our goal is to really screen everybody as much as possible.
We're getting there.
We're getting there. Erin, I want to come back to you next, because you touched on the idea that you did a pilot a little bit earlier. And I get the impression, I'm going to pause the screen share for a little bit. I get the impression that there are some unique challenges or barriers to achieving that goal of universal screening everybody, that there are unique challenges when trying to do the screening in homeless care settings. And when we say homeless care settings, we're either talking about in a shelter or a transitional housing program in the woods, or for a formerly homeless veteran in their own home. Can you talk a little bit about what some of those barriers or challenges to screening have been for veterans experiencing homelessness or housing instability or being formerly homeless?
Sure. So a couple of things come to mind. Initially, when we did our pilot, the homeless program was not screening. We were relying on primary care departments to do the screener. And oftentimes in the homeless program, we are seeing veterans that aren't yet connected to primary care. So there was a whole population of individuals we were serving who weren't getting screened at all. So that was one of the reasons we decided this was an important pilot to do. But one of the challenges with that is the screener is set up through our electronic health record as a thing that pops up. We call those clinical reminders in our system. So it gets done electronically. Well, as you mentioned, a lot of the staff in the homeless program are actually going out into the field, whether that's into homeless shelters and transitional housing, or literally in a field, in the woods, in an encampment. And frequently we don't have electronic devices that we take with us that help us access the electronic health record. So what we found right off is that we needed to have a paper version of the screener to take with us into the field so that we could actually complete that screener on paper. And then when we come back to the office and do our note from that encounter, we could put in that screener at that time. So that was one of the things. And there's also challenges with spotty Wi-Fi. When we did try and utilize some electronics, that has gotten much better over time, and that was a challenge. The other challenge that we had in implementing was just the fear factor. We had staff that were very concerned about really getting into these intimate questions. As you had mentioned earlier, a lot of them, they're very pointed questions, right? Saw the purpose, saw the value of it, but we're concerned about doing that, particularly when you remove the safety of the office environment. What we found to counteract that is that staff felt a lot safer and more competent in doing this assessment once they had the training and realized they would have the ongoing support from the IPVAP coordinators. Then their comfort level with doing this rose significantly.
Yeah, I wonder, and check me on this, I wonder how much of that comfort in doing the screens is really boiling down to, you mentioned the support, but also like the what's next. I know a lot of folks feel scared, especially in maybe like the suicide prevention realm of, if somebody says that, oh no, I'm having thoughts of harming myself, it's not just this lack of support, but what do I do next? Like literally next. And if I understand correctly, a big part of that support and training is not just how to do this, but here's the next steps, here's the resources, here's what you do. And that can be empowering for providers to do the screening. Did I understand that correctly too?
100%. Yeah, just any clinician, I think, has some level of trepidation to open that can of worms, if you'll allow me to use that phrase, on something so big if you don't feel like you've got the resources to follow it up.
Yeah.
Right? What if this is a positive, then what? So once they have the resources and the education that I've got support behind me, and here's my toolbox of things that I can immediately use to address this, it becomes much less scary.
Yeah. So Erin, you actually, and you touched on this, you did a pilot to essentially fix all of this, right? To actually create structures, support, protocols, so that homeless program staff can do this with homeless and formerly homeless veterans in our care settings. So I guess like the moment of truth has arrived. Like, can you tell us at least how that pilot went? Like, what did you do? What were some of the outcomes that you saw?
Sure. If you don't mind to pull up slide 17, I've got some of it listed there, but
yeah.
In essence, we decided to take this on as a 3-month pilot. We committed to a 3-month pilot, I should say that. And basically what we wanted to do during that 3 months is screen all of the individuals that the homeless program was working with, whether they were in our transitional or permanent housing, those that were new coming into our system. And there were, of course, as Dr. Bruce mentioned, some that would be excluded because maybe it wasn't safe, clinical reasons, or if they wouldn't consent to do the screener at that time, then they were excluded as well. But over this 3-month period, across all of our VA medical centers in VISN 9, we screened 577 veterans. And of the 577, 89% of those were male veterans. And what we found is we had a significant number of positive primary screens. Now that's the first layer of the 2 screens, 91 primary positive screens. And for all positive primary screens, then we do that secondary level too. And we actually had 30 secondary level positive screens as well, 10 from our female veterans and 20 from our male veterans.
That is kind of staggering. Could you put that into context for us? I know that when you had started seeing the data come in, that while the rate of male veterans might be a little bit more consistent with what we see in the research, it was still pretty a surprising outcome for you, for the team, in your teams in your communities, the number of male veterans being higher than anticipated. Can you share a little bit more about what some of the other maybe like insights or takeaways from the outcomes that, what do we make of this processes for us?
Well, for us, there were 2 big things for the homeless staff. Number one is that it blew the myth out of the water that this is a female veteran only issue that we should be screening for, right? It definitely told us 27% of the males, were a positive screen. We needed to be screening our male veterans and our female veterans. Yep. That was number one. Number 2 is that if we're going to help somebody address their housing stability, we have to assess for intimate partner violence because we already know there's a correlation. And it doesn't do the veteran any good or the clinician to be focused on just the housing piece and leave this very important contributor out of the picture. So if we don't ask, oftentimes we did not know that intimate partner violence was a part of what might be contributing to their housing instability. Once we started asking those questions, it gave us a lot more information that we realized we needed to address with them in their housing stability plans or treatment plans, we call them.
Yeah, fantastic stuff, staggering. I think the thing that is coming to mind for me, especially when we do these pilots that basically unearth stuff for us, especially for programs and services where the veterans, the patients, they're already working with us. And had we not done this pilot or this test or this innovative thing, like that didn't change the fact that these veterans, the 30 with the secondary screen, the 91 total with the positive screen, they still need the services, right? We just weren't aware until we kind of started overcoming the barriers that you identified and start asking the question, and then it's right there. I think that's, for me, the most kind of stunning bit of it all. Again, because whether or not we screened, like the veterans still have the issues that they still need help, which is really, really great stuff that you develop this pilot and really try to blow past those barriers. I also, just as an aside, because I know this is a really heavy topic, something kind of delightful about what you mentioned in terms of reducing the barriers, just going back to good old fashioned pen and paper. Can you anchor us in time? My understanding is this pilot actually happened before the COVID-19 pandemic, or like just right before. So a lot of the innovations and mass adoption of things like Zoom, telehealth solutions weren't actually there yet at the time. Can you anchor us in time of when this pilot took place?
Absolutely. Our pre-implementation was the quarter before 2020. So it was the very end of 2019. Our implementation phase was January 1st of 2020 to March 31st of 2020. So
so it actually like ended right this as the pandemic was picking. Oh my gosh.
Exactly. Yes. As a matter of fact, that impacted our last couple of weeks because, people stopped coming in and, we started going completely virtual right at the end of March. So our screeners fell off at that time.
Yeah.
But you're right. It has changed things because now we're in such a virtual world. We have access to iPads and, a lot more electronic resources. we do what we call VVC, or virtual visits, with veterans now, even those in the homeless program as well,
Yeah.
in addition to the in-person in-reach. So yeah,
Yeah.
it's a whole
And
new
I
world.
also, yeah, my other understanding is that because of some of the pandemic flexibilities, things like the CARES Act, American Rescue Plan, I think there was something about the Johnny Isaacson and David P. Rowe Veterans Benefits Improvement Act. Wow, I can just rattle that off. The Homeless Programs Office, we've been able to do a better job of actually getting phones, smartphones, and other internet-connected devices into the hands of veterans. So going forward, a lot of this stuff potentially could be done virtually. Is that?
That's
Yeah.
absolutely right. We have, within our VISN alone, we have distributed thousands of phones, smartphones, to
Yeah.
veterans in our homeless program.
Yeah, that's amazing stuff. I want to switch gears a little bit, and I want to talk about the key lessons learned, especially for those who are listening in. Maybe they're in healthcare and are traditionally in inpatient or outpatient settings, but maybe are dabbling with community-based settings. Maybe they work with veterans. Maybe they work with LGBTQ patients. Want to talk about some lessons learned and considerations and a couple kind of key topics. And Aaron, you touched on this already, but I want to kind of settle in with it a little bit more. What are those other lessons learned about technology, or do we cover it all just through just our banter back and forth?
I think that we covered all the technology pieces. The only other thing I would say is that we were also able to help the clinicians see not only the clinical benefit of doing this, but also realize that it wasn't overly burdensome. And I think that's important, because I know in the homeless program, and I'm sure this is felt across all medical disciplines, a lot of times staff feel overburdened with all of the screening assessments that need to be completed during a very short visit.
Yeah.
And staff were worried about that, but they found that it really wasn't overburdensome, and the value that it added clinically made all the difference. I mean, it was absolutely worth it.
Yeah, I also imagine, though, that there are opportunities for solutions to continue to reduce the burdensomeness of universal screens on the whole, whether it's this or even some of the other universal screens that VA may do, like stop smoking or dietary, all that stuff as well. And if I remember correctly, you mentioned the kind of the pen and paper version of the screening. It was actually almost like a full tilt script that went through all of the different stages and provided basically the language that all of the clinician had to do, if they were new to it or a little bit shy, was just kind of read through it together. And then it took you all the way through, as Leanne, as you mentioned, that universal education towards the end, and what are the next steps. And I mean, in some ways it's low tech, but it's still tech in a way that somebody doesn't have to memorize it or log in and get into like log into a laptop or anything, and just boop, 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 boop. Leanne, I want to come over to you next and talk to us a little bit about some of the policy implications here, especially for anybody listening in who's an administrator, maybe a hospital administrator, maybe an administrator of a healthcare system, maybe somebody who is a local, state, even federal level administrator who can shape policy. What are some of the policy implications that folks should be thinking about that emerge from this pilot?
Well, I think one of the things I'd like to mention is that this is so indicative of the VA's kind of quality improvement and systems redesign mentality that quality improvement is everyone's business. And so again, it started so grassroots, sitting around a table saying, hey, we don't know a lot about this. And Aaron sitting there saying, well, what can we do? Let's do something. And so it really started out there, in the field, at a facility where you can really see the implications. And so even though it was a small study, we hope that it will generate more research. We have a lot of research arms in the VA, so we've made this available to our real researchers. I say that because I'm not one. And there is a lot of interest in doing this in a broader scale and learning more about it from that more empirical way. And so this was the catalyst for so many different things. We have been able to use this as a foundation in policies and procedures. We've been able to share this across the country on the national level. We've held it up as a shining example of innovation. And so we are hoping that across both our pathways, both the IPVAP policies and procedures and homeless programs, that we can both come together to, as we rewrite policy, as we rewrite toolkits and procedures and things like that, that we can implement the structure and guidance needed that will help this expand. It already has expanded. I know that a lot of other VISNs and regions have taken this on, and it's been able to really give us some foundation that we've needed to take our screening further at the national level, to say, this is not a gender specific issue. We need to be screening all veterans. So this has helped us to make that case, as well as I've been able to present this information to higher VA leadership and other programs and things. So it's definitely is something that is spreading, and it's something that we can sustain. So it is informing policy, it's informing procedure.
Yeah, I want to stay on this idea of procedure a little bit, because one of the things that I heard from both of you, Erin in particular, just some of the things that you were doing to reduce the barriers, that the way in which policies and procedures, or maybe it's more accurate to say policy and training, implementation support, ongoing support, they're inextricably linked. That you can have mandates till the sun goes down, but none of that matters if you don't have a support system that helps providers actually implement it in a meaningful way. It's just yet another mandate. Can you just riff a little bit more about, how the IPVAP program, your staff and coordinators across the country really help with the implementation of that policy?
Sure. I don't know if that was for Erin or me, kind of both
maybe
of us,
for you, specifically for you, Leanne,
Okay.
as a national coordinator, because one of the things that I heard, especially when we were prepping for this, was just how valuable those local hospital IPVAP coordinators,
Absolutely,
being a resource to the homeless program staff, like almost on speed dial,
right.
so that they didn't feel alone. And that, what I heard from Erin, went a long way to increasing adoption, just that phone a friendness. And again, like, that infrastructure is critical, at least from what I'm hearing, of implementing and carrying out policy. That without that, it's just another mandate.
Absolutely. I think that's a huge key, is building that structure, from the training to the coordination of it, but really building the relationship at each one of those facilities, from the coordinator to those programs, program leads in the homeless program, which they already were working so closely together. I think Erin, and in VISN 9, with Erin being our VISN level, having visibility of both programs, that is definitely a best practice, in this particular case with these two programs. And I really love it that in their pilot, at the end, they polled their clinicians. As you can see, the results of even the clinicians, even though they were kind of nervous about it at the beginning, at the end they were saying, oh wow, this was important. As Erin mentioned, this was important. This was beneficial, and they've kept doing it. They have sustained it. And again, it wasn't mandated. That's the cool thing. Is you're right. There's, you can mandate things and it never get done, or not get done well, or, in some cases people see the value of it and they, do it because it's the right thing to do, and they want to continue doing it because that's how we take care of our veterans, and we keep, maintain safety and help enhance their, well-being and everything. So, the other flip side of that is you don't have to have a mandate. Sometimes people will just continue doing it because it's the right thing to do. But it really is informing practice and those relationships between the two programs, bringing them both together.
Yeah, let's settle on this idea of practice. Are there other additional takeaways from the practice side, especially for those listening in who might be clinicians themselves? Maybe you're a doctor, maybe you're a social worker, a psychologist, maybe you're a nurse listening in. From the practice side of it, what are the some considerations that they should think about? And maybe Leanne, I'll start with you first, and then Erin, I want to get your take as well. Yeah.
Yeah, I want to jump in. And at the national level, we see, as I said, we don't believe IPV exists in a vacuum. We know that it is connected to suicide, suicidality, homicidality, overall health and well-being, ER visits. So we know that getting involved early from a practice perspective and identifying those who are impacted by intimate partner violence. And again, in our case, we're looking at providing care for those who experience intimate partner violence in the past, trauma that's continuing to affect their lives. They're currently in these situations, or even those who are using intimate partner violence. We have evidence-based interventions for those who use or might be at risk of using, which kind of connects us back to the homeless programs again. As Erin mentioned, there's the Veterans Justice Outreach Program that helps veterans who are involved in the correctional side, which could be due to domestic violence and things, get reacclimated. We have a Strength at Home program that in many states is recognized as a intervention treatment. It's an evidence-based intervention treatment for those who experience, those who use or are at risk of using intimate partner violence. So it really starts from where veterans are. It takes into account their trauma. It helps them to build new skills and new ways of relating to others, and it's just really tremendously effective. And so from a practice perspective, it's important that, this understanding, we often in the VA say we're operating from a whole health perspective, but if we're not screening and asking about their relationship and where they're living, 24/7 of their lives and what kind of environment it is in, we're not really providing whole health. And so it is something that the VA is embracing as something that's very important and very informative of practice.
Yeah. Erin, I want to come over to you next. What are, especially from the homeless program side now, what are those practice considerations that, you heard from your social workers or your other staff about the interactions with veterans? What would you think our folks listening in need to keep in mind?
I think that something Dr. Bruce said earlier is something to go back to, and that is that we may screen someone who is experiencing or using intimate partner violence, and they may screen negative, and that could happen over and over again. So one of the key takeaways for me and the homeless staff is that regardless of how someone screens, when we begin the conversation about intimate partner violence, we also offer the education. Those are resources they can take with them, no matter if they have a positive screen or negative screen. And sometimes that's what makes a difference, because somebody may not be ready to talk about their intimate partner violence experience during that session. So the other thing is that we screen annually. It's not a one and done, but something that we're prompted to screen for annually. And if, as a clinician, there's something going on that's making me think, well, it's not time for their annual, but I'm curious about this, we can screen outside of that clinical reminder time too. So screen often, always offer the education, because today they may not be ready to talk about it, but tomorrow they might, so those are some of my takeaways.
Yeah, it's really good stuff. I want to shift gears a little bit before we get into our Q&A section. Just before we get to there, what's next? What's on the horizon? Erin, I want to stay with you. What's next for homelessness and intimate partner violence within your region?
If you don't mind to pop up slide 23.
Sure.
I will let you know that I am really happy to report our entire VISN leadership has been extremely supportive and encouraging us to continue to do intimate partner violence screenings across all of our care settings. So what that means in our region is that we are screening for intimate partner violence in all of our primary care settings and in all of our homeless and mental health settings. So I'm really pleased that we are doing a wide We want to catch, because a veteran might be involved in one of those programs and not the others. So we want to catch them through any entry point to make sure that we're doing that screening.
Yeah, great. Leanne, same question, especially from the national stage. What's next for the IPVAP program?
Oh, lots of things that have been heavily influenced by this pilot and the findings. One is we do have a national policy. We were mandated by policy in 2018. Sorry. It's VHA Directive 1198, and it was the first directive, a policy ever in the VA that really addressed specifically intimate partner violence, and we're already in revision. So a lot of this is really influencing how we rewrite and strengthen a lot of the language and directives or guidance in that directive. So that's in the process of being rewritten. In the meantime, we have revised and a little bit streamlined the text part of our what we call our relationship health and safety screen, what we're talking about and what we showed you earlier. And it's getting ready to be implemented, distributed across the country. We do have the electronic health record. So once a template is updated, it goes out to all VA medical centers, and it actually will prompt the annual screening of all veterans nationally. So this is going to expand nationally. Hopefully in the next couple of months that will be released, and we're really excited about that because we want to create that whole sense, as Erin was talking about, a no wrong door. We don't know where a veteran's going to walk in the door and feel comfortable enough, or to whom they will feel comfortable enough saying they're having some relationship issues. And we want that person, whoever they may be, to feel like they can do the screening, that they can give that universal education and mitigate that risk. And all of our toolkits regarding screening, we have an enormous amount of toolkits and resources and trainings and things like that. All of those are being updated as we speak.
Great. Okay. Why don't we open it up for some questions? I know there might be some folks in person. I know we're virtually, but if you have a question, actually, how should we do questions? You can type it in the chat, let us know on the audio. How does the rhythm work?
And then I can check the agenda to see if someone put questions in the Q&A there.
All right.
Keith, are you done with sharing your screen?
Yeah, let me share my screen. Stop. There you go.
Okay, awesome. Thank you. Let's see. No, I don't see any questions in the Q&A just yet. And then, yes, they have the opportunity to put questions in the chat. Let's see, we have a few attendees here, so give them a few minutes. And
yeah, we'll give them a few minutes. Yeah, if you have questions, let us know in the Q&A and in the chat. Otherwise, while we're waiting to check in, I'd love to do what is one of my favorite questions to kind of close presentations with, is your why. Usually whenever I do kind of interviews like this, it's usually in the context of veteran outreach, really focused on veterans. And I myself am not a veteran, which may or may not be surprising. But I have a history working in the homeless programs. I was a social worker, had a lot of veterans that I worked with, moved from homelessness to housing. And one of the things that was most important for them was to know that this was not just another job for me, that I was committed to the mission. And Leanne, Erin, both of you are hyper competent, hyper capable women who can do amazing things, but you're both working for us at VA with veterans, for veterans issues, intimate partner violence and homelessness assistance. So I'd love to know, like, what is your why for this work? What is your connection to this mission? Because again, you could be working literally anywhere else, but you're working here at VA on these topics, and especially with this pilot on the intersections. And Leanne, maybe I want to start with you. What's your why for this work?
Oh gosh, I come from a really long line of veteran family members. I'm not a veteran either, but I have worked most of my career with military and veterans, and I always take into consideration every veteran that I feel like we're addressing is like they're one of my family members. From grandparents to uncles to all the way down to my granddaughter in the Air Force right now, just getting out actually, and so. You know, I think about them when anything comes across my desk. You know, every one of the veterans are my family members. And I worked for the Army, Department of Army, for a long period of time, and I saw, you know, even more like that, more, you know, raw impact of service as the service members were coming back from deployments and what was happening. I was working as a social worker, you know, trying to help them with their families, and I just saw what they went through. And it's just really is a personal mission that anything I can do to help alleviate, you know, the impacts of the sacrifices that they've made is, you know, my honor. So I'm just thrilled to get this opportunity.
Yeah, thank you. Thank you. Erin, same question to you. What's your why for this work?
Yeah, similar. I have a lot of family members who've served in the military. And I truly believe in the mission that no veteran should be without a home. I believe that. The work is hard, but the rewards are so great. And that's what keeps me going.
Yeah, well said, well said. All right, quick check-in to see if we have any questions. Otherwise, we can go ahead and wrap.
No, see any questions. Thank you so much.
All right.
This was great. And yeah, I think we can wrap it up.
All right, I'll just do a quick little bit. Thank you so much again, Dr. Leanne Bruce, Miss Erin Solanskis from VA, the HIPVAP program, and the VISN 9 Network Homeless Coordinator. That's all for us today. We hope that you found this last hour to be valuable and that you feel empowered in our collective work to ensure that everybody has a safe and stable place to call home. Take care.
Thank you, everyone. Thanks, Sean.